Health Professions Workforce Programme Lead for Greater Manchester.
Thank you, Paula. We also have Rob.
Hi, I'm Rob. I'm the Project Admin at the Greater Manchester Training Hub for the GP Ready programmes.
Thank you, Rob. And we have Jonathan.
Hi everyone, my name's Johnny Henson. I'm a primary care workforce programme manager and commissioning as well. And I've got to go early because I've double booked myself, unfortunately. So I just wanted to bring to your attention the one of the programmes that's been newly developed and quite successful up to now is something called the GM Workforce Connect. And what this is a digital matchmaking service for jobs for the NHS around Greater Manchester. So it links basically employers to employees and vice versa and makes that connection. So somebody looking for a specific job in a specific area of Greater Manchester to a practice looking for a specific role or discipline in Manchester and links the two. It has been going out to all the practice managers through the practice managers forums. We've gone through, I think, everywhere up to now. So what I'm going to do, if you don't mind, is because I'm going early, I'm just going to send you all an email with just the GM Connect where you can just read a bit more further about it, sign up for it if you like. If you're a GP, we should already have your practice on the GM Connect, and obviously my details are down there. But if you're an OT student or an OT looking for work in Greater Manchester, it's a fantastic tool for you. So I'll just leave it at that, and thanks very much for that.
Thanks, Johnny. And lastly, we have Sam.
Hi, my name's Sam Howard. I'm one of the clinical leads for the Greater Manchester Training Hub, and I lead on the GP Ready programmes.
Thank you, Sam. Next slide, please. So as you can all see from the slide, this meeting is recorded so that we can share it on the Greater Manchester Training Hub website. Thus, please take note of this and you may leave your camera on or choose to switch it off. Please can I also ask everyone to keep their microphones turned off at all times unless when asking a question. There will be various opportunities for you all to ask questions. Please use the raise your hand function or type your question in the chat box when we reach each question and answer section. Sam will be monitoring the chat box, and it would be great if we could get some questions from you around what it is that you are wanting to find out from this webinar today, and also any questions from you that you would like to post for other members of the team. We will also be having some questions for you to take part in via MS Forms, so please join in and answer them. Next slide, please. So the topics for this evening's agenda are: what's your understanding of occupational therapy? We will shortly be putting up some questions on the screen for you to answer and would appreciate if you could all take part. We will then hear from Genevieve Smythe, a professional advisor from the Royal College of Occupational Therapy. Sophie will then run through Chantal Martin's slides, who is currently an occupational therapist working in primary care. Unfortunately, she can't be with us today due to unforeseen circumstances. And after each speaker, we will have the opportunity for question and answers. At the end, we will have some more questions for you to see what you have picked up on from this webinar, so please do join in once again. And as mentioned earlier, please keep the questions and feedback coming in the chat box. Next slide, please. So if we can now take a few minutes to answer some questions, please.
Okay, so what I want to do is I'm going to pop some questions up that hopefully pop up on your screen, and it's just a bit of interaction to gain what your knowledge is at the moment, and then hopefully by the end it'll all change. So the first question that is going to is specifically for those if you currently work in general practice. Do you currently work with a first contact occupational therapist or other type of OT? So it should be popping up now. So we've had like 9 responses for the moment, so it's really good. So you can see what the responses are. I'll leave it up there. I think you should be able to go back into it. So the next question is, how well do you feel you understand the role of an occupational therapist in primary care? So
well, I'm just aware that how many responses? We only had about 11 people respond then. I'm just wondering, do we need to just give people a little bit longer, or are people having trouble answering?
Sorry, apologies. Where are we supposed to be answering this, writing it? Is it on the chat or?
It should pop up. There should be a big pop-up forms.
On the screen?
Yeah, something's coming up for me.
Let me stop sharing. Maybe if it's because I'm sharing the content, I'll stop sharing. I'll try to stop sharing. Where we go? Stop presenting. It's that one. Let me relaunch it.
It's really quite good when it does, well, when it works, if you can access it, because you just literally have to click a button. So thanks for your feedback, 'cause it's important that we give everyone the chance to answer. Yeah, I think we've got 11 people that have responded.
They're both live at the moment. If on the top of your screen, you might come up in your chat as a question. So yeah, if you go in the chat function, it is there as a question in the chat function as well. You can scroll up and see if you're working in general practice, so you can answer that one now. You can also answer the other one at the moment. How well do you feel you understand the role of occupational therapy? So yeah, I can see we've just had another response for the first one. And the second one, we've got quite a few more. We've got 15 responses now. So someone's pointed out it might not work if you're on your phone. Sometimes it can be a bit dodgy on phones because of obviously the size of Teams. So yeah, that's quite good. What have we got? We've got 29 people in the meeting so far at the moment. So we've got about 16 responses for the next question. So that's quite good. So it's interesting. We've got some understanding. Some have got quite a poor understanding. The majority do have some understanding, which is quite good. So the first one is, do you know, the next one, sorry, not the first one. The next one, when I launch it, is, do you know what a first contact practitioner is? So this is just in general, not just first contact practitioner OT, but a first contact practitioner. And that one is launching now. Again, it's just in, oh, that one nice. Everyone's on it now. Now 15 responses straight away, 16. We're already up there. So most people knowing what a first contact practitioner is, that's really good. Now we're going to have a bit of a word cloud, so I'm hoping it pops up on screen. So I want a bit of free thinking in terms of how do you think first contact practitioner occupational therapists can support the service in primary care? I've got lots of these forms popping about, so it's just going to take me a sec to launch this one. Perfect. So is the form popped up for those on a computer? So I think you have to put in a response to see the results as well.
So this is just free text. How do you think FCP occupational therapists can support the service in primary care? Are you able to make it any bigger, Rob, or not?
No, sadly not.
That's all right.
I'll suggest that to Microsoft. I might actually do that. You can go on the website and they have suggestions whilst people are putting all these stuff. And if it gets ranked up, then they actually develop it. So we've got quite a few here: rehab, mental health, GP time, health and GPs, complex, preventative work, relieving of pressure, hospital admission, history gathering. So we're getting quite a few responses here. So we've got 15. That's quite good. Fab. So assessment, critical communications come up. That's quite good. Getting more responses now. 22. I'll just leave people just to type a couple more responses. And like, you can keep going and adding to this as well as we go along. and it'll actually give me a time of when you added it, so I could even see how your development. If anyone wants to scroll up the chat and do that, that would be nice.
There's a great comment in the chat. I have no idea how you can help. Brilliant. You're in the right place, Jill.
Great. I'm hoping you can give us some ideas.
Well, let's hope so. That's the aim.
Right. Responses seem to slow. We've got quite a few responses, so I'll move on to the next one. So currently, as in based on what you know and everything, would you consider employing an occupational therapist in your general practice? Watch that one. So we have got this one, we've got a directly related question at the end, so it'll be interesting to see who changes their perspective, or what percentage of people do it. We've got quite a few still saying they would though. That's really good.
I guess we're also interested in those that wouldn't, and please be honest. No offence will be taken here.
Sorry, can I comment again? Jill Edmondson, GP. I was given to understand that the PCNs are thinking of employing occupational therapists, and that's why this webinar's been set up. So we wouldn't be employing you directly. The PCN would be employing you. Just that question doesn't quite make sense to some of us, because we wouldn't be the employers, just to let you know.
Okay, yeah, I understand what you're saying. I suppose it's in theory, would you consider having an occupational therapist in your practice? Maybe, yeah, we should have reworded that rather than talking about employment.
I mean, just to say there are different workforce models about how occupational therapists across the UK are working in GP surgeries. And so maybe when we get to the questions and answers section, we can look at that in a bit more detail, because it's happening in different ways in different places.
Fab. So I'm just going to share my screen again. Bring up the slideshow.
There's still a box on my screen, so I don't know if you've still got a box on your screen, just click the right hand cross and it should disappear. If you've still got the little black box in the middle. Is it gone for everybody?
Is it, would you consider employing occupational therapists? Was it the
No,
last?
it was the word cloud.
The word cloud.
It's gone now. Just wanted to make sure. Okay, shall we carry on?
Thank you for that, Rob. I would like to now introduce to you all Genevieve Smythe.
Hello, hi Hamira, and hello everyone. Thanks ever so much for that introduction, and really interesting to get that quick overview of how much people know, and I'm always really intrigued to hear the answer to the question about whether you'd employ us in primary care or not. So anyway, hello, yes, I am an occupational therapist. I work at the Royal College of Occupational Therapists, and part of my role is to have national oversight of the development and rollout of occupational therapy in primary care in England, in Scotland, in Wales and Northern Ireland. And as I said, it is different in the different countries. It's even different across England. Next slide, please. So I am going to cover what is a first contact practitioner? And I was delighted to see actually that a lot of people in the audience said they had a good understanding, that there are sometimes some misconceptions about what an FCP is. And in case you're wondering at this point, why on earth am I talking about FCPs? Of course, the R's funding was set at this level of practice. So that's why I'm going to be talking about specifically what is a first contact practitioner occupational therapist. I'm going to go on and talk about our occupational therapy superpowers, how we can help you in primary care, and then give you some learning from our early implementer sites, what's worked, what hasn't worked, and finish with some information about resources. Next slide, please. So to this, I'll be interested to know how many of you who said you had a good understanding of first contact practitioners, whether it matches. So this is the official Health Education England definition. So it's a diagnostic clinician working in primary care at master's level. So that's post-registration master's level with a minimum of 5 years postgraduate experience. They work with people with undiagnosed and undifferentiated diagnoses, managing complexity. I noticed the word complexity popping up there in the word cloud. So managing complexity and uncertainty as the first point of contact for that patient or carer in primary care. So as I said, the description I'm going to give and the examples I'm talking about are at this advanced level of practice. And that advanced level of practice is at level 7 of the HEE multi-professional framework, if you're familiar with that terminology. But in essence, these people have excellent, top-notch clinical skills. So in terms of where they are clinically, they are just sitting below consultant level practice. Next slide, please. So what are the FCP occupational therapy superpowers? So these, just to explain, are key clinical areas according to the scope of the FCP role. So the scope may be different in different areas, usually driven by demographic need and the need of those GP practices. But what's crucial here is this means that primary care staff such as receptionists or patients who are self-referring for the first time before having a diagnosis can be directly triaged to the FCP occupational therapist. So that's when they're presenting as adults with undiagnosed but suspected mental health problems, contacting the surgery for the first time. As older adults presenting with what we suspect will be their first episode of frailty-related problems, and for working age adults requesting a GP fit note. So I'm just going to say at this point that although these are our 3 superpowers, there's lots of information out there about these 3 superpowers, this is not an exhaustive list. But at the minute now, these are the most prominent areas of clinical practice for FCP occupational therapists across the UK. Now, there are some interesting pilots going on. We have a pilot somewhere of a children's occupational therapist working in a GP surgery, and we also have a pilot of a social care occupational therapist, but they're very small at the minute. So these are the largest areas of practice, and I would say at the minute are our greatest gifts to you in primary care. Okay, next slide, please. So I'm just going to go through each of these areas in turn and explain in a little bit more detail. So for us around frail older adults, that goal is admission avoidance or speeding discharge from hospital. So admission avoidance or speeding discharge from hospital and enabling the person to remain in their chosen home environment, whatever that environment is. Certainly a lot of the occupational therapists working with frail older adults will also work in care homes. Some of them actually have specific roles just going into care homes and doing that work around care homes. And obviously palliative care is usually a strong theme in that as well. Dealing with undifferentiated diagnosis and medical red flags. Quite often they'll use a risk stratification tool to identify people who can be reviewed by the occupational therapist rather than the GP. And they accept self-referrals and referrals from families. This particular service offers a rapid access, including an assessment of the home and short-term occupational therapy interventions, including advice on how people can be safely managed at home. 75% of people who come into this service are seen within 24 hours. And I know there are ambitions to actually see people even shorter within a 4-hour period, for example. But initially, they set the bar at 24 hours. So the service has been really successful. It's been in existence for about 4 or 5 years now, and it's now expanded into a much larger primary care occupational therapy service. So the advanced clinicians went in first, and they set up and developed the structure and the governance of the service for safety and assurance. And you can see some of the figures on the slide. So next slide, please. So that's frail older adults in a nutshell. On to thinking then about adults with mental health problems. So in essence, our role here is about empowering adults with mental health problems to improve their everyday lives. Often these are patients who need more than psychological therapies such as IAPT, but they're not going to hit the bar for referral to secondary mental health services. So they're in that space. Yeah, sometimes what is already on offer in primary care is not enough. It's not hitting the mark, but they're not going to be seen by a community mental health team. And I'd argue they don't need to see a psychiatrist or a CPN. Some of those people actually have struggled to access IAPT or social prescribing, usually because they've got a higher degree of complexity, or they have accessed those services. But what we find is they haven't translated into any real change. So these are the people who you've given them your best shot and they just keep coming back. For whatever reason, it's not working. So as I said, these people often present with a higher degree of complexity, quite often non-visible disabilities. Occupational therapists are usually really great at picking up where you think it's one problem, and it may be that problem, but often actually there's a more complex picture sitting behind that, which is really driving their problems. So some of those will be about neurodiversity, often undiagnosed head injuries, mild learning disabilities, literacy problems. And quite often the occupational therapists are pinpointing those unresolved underlying issues that result, as I've mentioned, in either frequent spectrum, those excluded communities who are actually not accessing primary care, so they're not getting access to those gold standard treatments that we know will help them for their mental health problems. Again, I won't go over the figures on the slide, you can see those. Okay, and next slide, please. So we've spoken about frail older adults. I've spoken to you about adults with mental health problems. This is the other biggie for us, adults with health and work problems. So providing vocational support. And a lot of this in this health and work space is about helping people to self-manage their problem. They're off work sick, requesting GP fit notes. Quite often that is around mental health and or MSK health problems, and increasingly it's also around long COVID. So as I said, the occupational therapists offer self-management advice to target the health problem. So we're giving health advice to tackle that health problem, but most crucially, alongside that, we're providing detailed, tailored advice on what are the workplace modifications or job modifications that can happen to help that person get back into the workplace. And part of that can be an offer of liaison with the employer. We know that's one of the biggest stumbling blocks for people not get the longer you're out of work, the less likely you are to get back into the workplace. And quite often people need more detailed, tailored, specific advice. And that's what occupational therapists can provide. We have a tool, you may be, if you're not familiar with it, there's a picture of it in the middle of this slide. It looks exactly like a GP fit note, except it's called the AHP Health and Work Report. And that's one of the major tools that we use. It's a recognisable document for the patient and the employer. And most crucially, it can also be used for statutory sick pay. So just remember that 80% of GP fit notes are used for statutory sick pay. Your occupational therapist can be using this for statutory sick pay. Okay, so that's the three main superpowers. If we go to the next slide, please, I'm just going to give you all of these services that I've described and these examples that I've described so far were set up pre-COVID. And this is an interesting one because this was set up during COVID as a result of the mental health crises that were happening particularly during the early lockdowns. So we know that those early protracted lockdowns had led to an increase in loneliness, isolation, substance misuse, domestic violence, particularly for those who were shielding, and we're familiar with that sadly now. And that obviously the knock-on impact of that was those people came to primary care. So there was a huge increased need for urgent mental health support, way over and above what we had experienced before. So the ICANN primary care was piloted by occupational therapists, completing those mental health assessments as an alternative to the GPs, exactly as I've previously described, using occupation-focused interventions and crucially linking into local resources. For example, in this particular area, they have a series of hubs called ICANN hubs. No restrictive eligibility criteria, because that just puts people off, makes everything difficult. And the programme offers easy, earlier access to prevent and mitigate health inequalities, offers really practical help with this focus on opportunities for people to get active. I don't just mean physically active, I mean active in all aspects of your life, so to get active again in their everyday lives. So the co-production part of the project developed, and that was linking the occupational therapy primary care services with community drop-in spaces, and on offer of unlimited intensive employment support and volunteering opportunities, with an enhanced offer back to volunteers of support, supervision and reflective practice. It's so easy when there are community resources just to send people off to the community resources, and we know 60% of people will do that. But actually there's another group of people, usually with a higher degree of complexity, who need an additional layer of support, and that was what was put in with that additional offer back. So not we just send you off, but there is something here in the background that we can offer you to check that you embed and the change really happens. Okay, next slide please. So results of the pilot. I won't go over all of this, but you can see people were getting more practical self-management advice than they were in the GP appointments. The GP appointments were avoided, and there were cost savings made due to reduction in GP appointments and possible onward referral to secondary care. Okay, next slide please. So a photo and some quotes from GPs. I won't read all of these, but I'll read the last one. Long COVID increasingly is now causing increased disability, threatening people's ability to work and function. Early upstream access to occupational therapy support in primary care has never been more needed. Okay, so next slide. So this is shared learning, and obviously in terms of the ARS funding, the additional role reimbursement scheme, that has been the driver for the new allied health professional roles in primary care. Our physiotherapy colleagues and our paramedic colleagues, their funding came through probably about 2 years ahead of occupational therapists. So they've been really great at helping share some of their early learning, and ourselves and the think about actually what are the things that help embed our clinicians, our first contact practitioner, AHPs, allied health professionals in primary care. And they look really straightforward. That top point, take the time to ensure everyone understands the role, purpose and function of occupational therapy. Now, what we've found, some of the feedback we've got when we've started going into the GP practices, not only GP practices have been under the most astonishing burden, an unprecedented burden. Even before COVID, primary care, the landscape is dramatically changing from how it looked 10 or 15 or 20 years ago. So our occupational therapists and all the other new roles, we've got healthcare coordinators, we've got physician associates. And one of the things we were running into is that's really hard sometimes, but a really busy practice team to think I've got these new people, I've got pharmacists turning up. So actually allowing some time and coming back to this about what is the role and the purpose and the offer of this occupational therapist, or this physician associate, or this social prescriber. What's the difference and what are the similarities? But that simple step can really trip things up if it's not done well and revisited. The second most crucial point that we have learned is about care navigation. Now, I have been saying to you that this level of clinician, they're one below consultant level. Okay, so you got top-notch people here. The point of them is that they can see patients direct. treat. So if you are seeing, if these people are still coming into primary care via a GP or a practice nurse and then being referred onto the FCP, that's not really the role and purpose and function of the FCPs. So how do we ensure that the patient and the carer get to see the right person at the right time in the fastest possible way? However those patients are accessing your service and getting appointments, whether they're calling, they're coming in, you've got some online triage system, working out how we build these new FCP roles into those systems so it's most streamlined for patients and carers, because the risk is we just add another layer of bureaucracy, and GPs haven't got time to fill out referral forms. That's one of the things I've definitely learned. So what are the ways that we can work out safely what is the safe way of sending some of these patients, as many as we can, directly to our FCP level clinicians. I've spoken about induction. I won't go on more about induction. It's obviously the way we do induction has changed during COVID, but I would say there's probably a relationship about the sense of belonging that someone has to a primary care team and how long and whether they stay or not. Supporting your occupational therapist to integrate into pathways. So at the minute, because most of our occupational therapists in England, longest in post is possibly 18 months to 2 years. So most of your new clinicians are going to be coming from secondary care. So their knowledge of secondary care and their knowledge of community-based systems is pretty good. So how can you maximise that knowledge and those links and those networks and the pathway understandings that they've got for primary care? That's really, really crucial. So they should be coming in with a good layer of knowledge. We don't want to lose that knowledge. We want them to work well. We want them to bridge and be the transition points effectively between primary and secondary care. Support and supervision is crucial, and I was having a look at the questions that people had sent in to us in advance, and there were some questions about that. And I'm really happy to go into this into more detail. But if you think that doctors and nurses have brilliantly been in primary care for years and years and years, we haven't. So we have excellent clinical skills, but there is going to have to be some support and supervision to check that our clinicians are safe and robust and are setting up good quality pathways and service. So you are assured that we are a safe pair of hands in your team, but we can't do that without checking those therapists have got support and supervision for the pathways that are out there for them. And lastly, I would say there are loads of resources out there. Draw on those resources because they're a real gift. Okay, next slide, please. So we do have Paula Breeze here, who you might recognise as the face of our roadmap. So we have a large, this is a bit of a beast. I think it's about 170 or 80 pages, but we now have, I've been working closely with Health Education England to for about 18 months to produce an in-depth, detailed descriptor of what is occupational therapy at this level of practice in primary care. What are the capabilities? What are the core capabilities where they cross over with other advanced practice clinicians? So like dealing with complexity, knowing when to deviate from protocol, dealing with red flags. What is the core set that would be the same for a nurse or a physio? What is the occupational therapy specific capability set, and what is the capability set within those superpowers? So that is all in that document, as well as the educational pathways, because again I noticed there was another question from someone about what is the educational pathways. Well, this is the document that you want. I could talk a lot about this document, but I will say it's a genius document because most questions that you will ask are probably in that document, so I would recommend it to you. Next slide, please. here's some more links. So I've described to you the occupational therapy superpowers. You can have all of them for podiatry, dietitians, physiotherapists, paramedics. They're all there. There's the link for the roadmap. And we provide support for our occupational therapists who are moving in or thinking of moving into primary care or establishing services. So they have a place where they can come and share best practice and learn together. So we've got regular monthly meetings. So please direct your occupational therapists, or if you are, come and join us. And very last slide, please. I have spoken about the additional role reimbursement scheme. Now, I know because of the massive rollout now and pressure in primary care about the delivery of the booster, there are some temporary pauses in the QOFs and in the Impact and Investment Fund. But there is a crucial point here about funding. The R's money is the only thing that is driving occupational therapy in primary care. That finishes in 2024. The Impact and Investment Fund, I think, is the next layer of funding that we need to look at for thinking about workforce transformation in primary care. And I know there's been a temporary pause, but when it's restarted again, I think if you think about, there's 5 themes for the IIF, for example, there's one about health inequalities. We can really think about sustainable ways of expanding the workforce so they can help you achieve those outcomes in the IIF. That would be my last message. Think about ours, but think about the IIF funding as well to support workforce transformation. And I'm going to stop talking now.
That was great, Genevieve. Thank you so much for that really informative and wonderful presentation. Does anybody have any questions?
As of yet, there isn't any in the chat.
I've seen a hand go up. I think, is it Stuart's going to kick us off with the first question?
Yeah, hi Paula, hi everyone. I'm part of the recruitment of the R's roles at the minute. One thing that we're struggling for is to find the resources themselves. What's the pool of people like available for primary care for occupational therapists?
Sorry, when you say you're struggling to find resources, do you mean you're struggling to find occupational therapists?
No, I mean in other additional roles, apologies. So such as recruiting paramedics or other additional roles, we've struggled, just the people aren't there. What's the pool of resources available like?
Yeah. So I'll talk about workforce then. Okay, so I'm going to just state the obvious, but there is a national workforce crisis in every single professional group. Yeah. So I was talking earlier on about different workforce models. So this is crucial. So first of all, having looked at different ways that people have approached this, it seems to be most successful where at the outset of this journey, you get the system partners together, because you've got paramedics, you've got occupational therapists, you've got nurses, you've got physios, they're out there in the system, but the system has to change. Yeah, because we need to bring more of the workforce into primary care. And I've always said we can't have workforce transformation in primary care without having transformation in secondary care. Because at the minute our therapists are in secondary care, our drive is to ensure that we can transform both sides of the balancing whatnot thingy.
Absolutely.
So I think it's about having those wider system discussions about, well, where are the paramedics and the occupational therapists, and how are we going to, it's not just about making the roles attractive, is it? It's about having that discussion about, so for example, the paramedics have done very well at setting up rotational models. So this would be where you come to an agreement. I mean, I think paramedics are employed by ambulance trusts, I think. But for occupational therapists, the obvious thing will be to work with secondary care who have rotational systems, and think about if we want to pilot this or put a first toe in the water, is there a way we can have a secondment or put our occupational therapists on a rotational system as a way of checking that we're not destabilizing one part of the system to bring our workforce into another part of the system. So I hope that answers your question. I think it's about system level discussion.
Yeah, absolutely. And I guess this is the start of that conversation for ourselves. Appreciate it.
Can I just come in just to say that alongside promoting the superpowers of some of these roles to yourselves, it's also, we've got to do the same piece of work with our practitioners, because a lot of them won't fully understand the role, that how their role can be transferable in a primary care setting. So we've got a lot of work to do to make the roles attractive, to let people know the scope of practice, and to provide them with that knowledge. So I think there's a comms piece, and I'm glad to see that we have got some occupational therapists on the call, who hopefully might have their appetites whet by this and be looking out for those roles now. No,
it's been really educational so far. Many thanks.
Nick, are you an occupational therapist?
I'm in secondary care, so I'm hearing everything you're saying. I totally agree.
Yeah. There's people out there who are perhaps stuck at that band 6 level and they feel there's nowhere in my team to go. The career progression is limited. So this working at a level 7 master's level is a fantastic career development opportunity for some of our practitioners who are in secondary care and feeling they want a new challenge. So there's alongside the benefits, which Sophie will talk about shortly, it's great for the individuals to have that career progression in this way.
Totally.
Who else has got the hand up? Jill, did I see your hand up?
Yes, hi. Excuse me. I spoke before. Hi, I'm Jill Edmondson, a GP. So I'm converted to the superpowers and I want 4 of you in my practice right now. But I'm not joking about that, because the overwhelming, unlimited waves of demand that have been hitting us since pre-COVID, as you alluded, and the 130% increase in workload since, we cannot sustain this in most practices. Where I practice in Manchester, there are at least 2 GPs short in the practice, and there are loads of others in our network in the same position, never mind across the city. But my question, so it's great, and anybody who can help us filter out that undifferentiated demand and have it directed to a person who can deal with it, not necessarily who a GP as a doctor's trained to deal with complex medical problems, is brilliant. So I just wanted to clarify, you mentioned this band 7 or stage 7, and you said it was 1 post below consultant. Do you mean a consultant occupational therapist?
Yeah, absolutely. So I'm sure you're familiar with the concept of consultant level nurses.
Yeah. That's fine.
So it's exactly. Yes, sorry, I didn't mean medical consultant. So exactly the same way as for nurses, allied health professionals can work up, and interestingly, Scotland. The funding, England was a little bit slow, I would say, in the funding for occupational therapy in primary care, but Scotland and Wales, their funding came through first. And so they've actually got some consultant level occupational therapists working in their primary care services. So yeah, that's what I mean.
Okay, no, but that's great. And again, before this talk, I understood OTs went into people's homes, came from the hospital after post-stroke, commonly, or with the frail elderly coming home, and trying to help source everything so that they can manage independently at home and go back to work. So but obviously the consultant level is an independent analysis or assessment. Do they prescribe? Can they prescribe?
No, unfortunately, we're in an ongoing fight with NHS England. So I would expect that would be on the horizon in the next 4 to 5 years. But the roadmap is really clear about what we can and can't do in medicines. Actually, there is a fair amount that we can do that you would expect at an advanced level of practice around medicines optimization. But obviously, a lot of that will involve, going back to the independent prescribe, because obviously it's all done safely and with the normal scope of practice. But at the minute, unfortunately, we can't be independent prescribers, no.
Okay, that's fine. It's just good to know. And then my final question is about I fully understand it's important that all the staff know, and especially our receptionists, in terms of signposting patients for your service, which is great. But I would be happy to involve, have practice meetings or discussions where we discuss appropriateness or referrals and patients. But I guess my question really was about the level of supervision required. We've had ARRS pharmacists come into post who've only worked in the hospital, not the community, who have no idea what they're doing. And as a practice, we don't know what they can or should be doing. And actually, our CCGs have taken them most of the time for the vaccination centres. But it's just been a rather disappointing result for our practice personally, from having this person in who we thought was going to do great stuff for us with our patients. So I think that's a little bit about the training on your end in working with primary care and GPs, which I hope is being given. But I'm just reflecting back from that group of professionals, that wasn't the case.
Yeah, and I guess what's happened is because the pharmacists were one of the first tranches, I think, of money, and of course we've learnt from that. And in the roadmap, there's about 2 pages of the different types of supervision that are required, why it's required, who provides that. I'm just doing my roadmap supervisor training because there is a developmental journey to help that transition. We were just talking earlier on about actually how are people going to transition from secondary care into primary care, because it's not, what we don't want is them just importing secondary care into primary care. That's not the point at all. So there is quite a lot of robustness and richness in that that roadmap about how can we get this supervision. It's really interesting because I was in another meeting a couple of days ago, and this GP said to me, "You need a lot of supervision." You know, why are we going to employ you? You need loads of supervision and help. And what I was trying to say was, you know, you need to understand this is a transition for a whole profession. We haven't been in the primary. You are the experts in the primary care space, so there will be a greater amount of support and supervision that a new clinician will need in primary care that won't be ongoing. It will be more intensive. That is absolutely true. But that's to assure safe practice. That's what we would want to do, to assure safety and governance. So so that's really crucial. But I take all your points for supervision. We're definitely on a journey with supervision.
Yeah, and I'm sure in an induction style supervision that would be fine, but it is off-putting to a lot of GPs to think it's like, you know, training other members of staff. How much time would that require? And I would just like to finally say that I hope that within the service, whoever, whether it's sorry, I don't know exactly where you're from. I know you're from the Royal Group of OTs, but locally for Manchester, is there going to be the opportunity for this group or this cohort of people that hopefully you can, you know, recruit and put into practice? Is there going to be some kind of general group supervision lessons learned so that the staff will actually learn, you know, maybe one practice isn't doing it in the ideal way, or maybe they are and they want to share that, but so they can get best practice experience and share that amongst themselves? Is that planned?
Judith, I'm just wondering if Judith wants to come in from a Greater Manchester perspective to answer that question. Sorry, Genevieve.
Yeah, I'm absolutely fine with that. Yeah, so I'm currently a clinical educator for the Greater Manchester Training Hub, and I lead on a GP Ready programme that is for all the AHP, FCP roles. And part of that process is to help support people who've moved from secondary care into primary care to become primary care ready. We're not going to be able to do the direct supervision, but we'll be helping your people in place in jobs to actually gain the skills that they need, the soft skills that make them able to transfer those secondary care skills into primary care. So this is a fully funded programme for people who come into Greater Manchester, and there is a supported funding package for the supervision as well. It is limited per PCN and per people that come in onto the programme, but it is there and it is running at the moment.
Okay, sorry, I don't want to take too much time. So just a final point about that. The pre-supervision is great, but they need ongoing group supervision, I feel, afterwards. We have a focused care worker. I couldn't tell you what service she comes from. She's wonderful. It's like advanced social prescribing and support for patients, some of which your practitioners may do. But she has some kind of group work that just checks where they're at, what they're doing. She can take problems to that group who can help her find solutions. So I think that needs something to be in place if you can.
Yes, so the GM Training Hub does have actually a peer support group for each of those professional groups, which is there for people who come on programme to have exactly what you've said there.
Okay, thank you.
Fantastic. Ben, thank you for waiting so patiently.
That's all right. I'm really conscious of time, so I've got 4 points that I'll make. So the first is about Genevieve. You mentioned about the workforce getting together as system partners to look at how we do this. for the first contact practitioners for physio in Manchester, we wanted 14. We employed 14 across that. However, when we look at the context of that, there were 130 that were required across GM. In fact, it was slightly more than that. So that's about the consideration. That talks to your first speaker about the availability of these people having these qualifications in place. The second point that I will make is this is really important. Anybody that comes into primary care is not there to replace somebody in secondary care. And certainly when we went out and we offered 14 across Manchester, the feedback that we got from the primary care networks was that we absolutely needed to demonstrate that primary care was not paying for a place in secondary care as a result of that we weren't just shifting a resource from one place to another. And we needed to demonstrate that with every role that we had in. In terms of the R scheme, the current R scheme, there are some limitations in there in that you can only claim the salary, the tax, the NI and the pension contribution. There's a whole load of other considerations that need to be taken on board as well and negotiated with the primary care network, such as supervision, employment, equipment, all the other things. These have costs within them. Those need to be calculated and defined as to who will pay them as part of the agreement moving forwards. And that's it for now.
Okay, I don't know what if people have got to shoot off at 7:30, that's absolutely fine, because we weren't, I suppose, foolishly, we didn't anticipate this level of interaction, but this is actually fantastic and it's exactly what is required. So I'll hand you back over to Mara, and I'm just thinking, Sophie, we probably need to scoot through your presentation. No pressure. Just because of time. We will be able to hang around a little bit after, but I'm aware that some of you won't be able to, so that's absolutely fine. Oh, Himera.
Yep, thank you. So I would now like to introduce you all to my buddy Sophie, who will take us through Chantal Martin's slides.
Thank you, Himera, for that introduction. So hi, everyone. My name's Sophie, so I'll just, aware of time, run you through Chantal Martin's slides this evening. So Chantal is currently an occupational therapist at the Haywards Heath Central Primary Care Network in Sussex. She has kindly consented this evening to providing her contact details. So please, if you have any questions that you would like to ask her directly, then just make a note of that now, and I'm sure we can pop that in the chat box as well if anybody misses that. So next slide, please. So what is occupational therapy? I think it's important that we understand what occupation is from an occupational therapist's point of view. So we look at all people as occupational beings. We have an intrinsic need to engage in a range of activities in our daily lives to sustain our health and well-being. So occupations are meaningful or purposeful activities that allow people to live. So meaning and purpose is determined by the individual. People shape and are shaped by their experience and interactions with their environments. So identity and occupation are intrinsically linked. So we do in order to be, and who we are determine what we do. So occupational therapy provides practical support to empower, facilitate recovery, to engage with or reconnect to meaningful occupations to the individual. So therapy can facilitate ability to engage with an activity, and the activity itself can be the therapy to aid recovery. Next slide, please. So what benefits will having an occupational therapist bring to your practice and your patients? So firstly, occupational therapists, we will look at what it is that really matters to the individual. We'll look at what's impacting on their ability to do something. Where's the issue? Is it in the environment? Is it at home or work? Why is this an issue? Who is supporting them? What have you tried and thought of to resolve already? And how are you doing it now? So what other options are also available, and can anything be changed to make it easier? And is there also anyone else who could help? Next slide, please. So these next few slides, they just give us some patient examples that Chantal has experienced whilst being in the primary care role. So the first example looks at a long COVID referral. So after the pandemic, occupational therapists are working with a significant number of long COVID patients, both pre and post contact with the post-COVID assessment team. So many of these patients are experiencing debilitating symptoms. It's affecting their work and daily occupations. So an occupational therapist is able to discuss these symptoms with the patient, looking in depth at their daily routines, activities, and how this impacts on their daily lives. So as a treatment plan, we can give advice on long COVID. We can provide symptom management using energy conservation techniques and fatigue management strategies. We can provide emotional support for the psychological impact of the debilitating condition. We can provide AHP health and work reports, looking to make reasonable adaptations in the workplace, looking at benefits, support and connections, breathing and exercise apps. We can participate and collaborate with the MDT in discussions to case manage the treatment. We can provide equipment to enable bathing safely, for example, linking in and collaborating with post-COVID assessment team clinicians, and linking in with food banks and community larders. Next slide, please. So our second case example. So this looks at a 23-year-old female who was referred for long COVID and anxiety. So on the first call that Chantel took with this lady, she wasn't experiencing long COVID symptoms, but her anxiety had increased from panic attacks to suicidal thoughts. So she'd recently moved to an area, she'd left a job from stress. She was suffering low self-esteem, recently been prescribed sertraline after suffering from long-standing anxiety. She described her life as a mess with other multiple issues, moved in with a boyfriend and family, having left a job and flat in London. She was originally from another country and she stated nowhere felt like home. So at this stage, she had not needed a referral to secondary care mental health team. So how did Chantel, as an occupational therapist, assess and provide treatment in this situation? So she helped to explore the patient's suicidal thoughts. A mental health safety plan was discussed and contacts given. A recovery start assessment was completed over time. This implemented small measures throughout, improving the patient's mental health. So this patient began to identify hope and confidence for the future, prioritising areas that were most important to her. She's since gained employment, considering a master's, and has also enrolled on recovery college courses, RE mental health and community exercise groups. So next slide, please. So I won't run through all these, but as we can see, these are some really lovely quotes that Chantel's patients have kindly shared. We'll just take a moment, and then Rob, when you're ready, you just up to the next slide. We do have some more. You will notice, so at the bottom, the last quotation on this slide, it's highlighted in red, and I know Chantel would want me to share this with you all tonight because it was really special to her. So this patient came with, "You do not realise how great you are. I would not be here without your support." So this was a patient who at the time, she didn't disclose to Chantel about suicidal thoughts. And I think after reading this quote, I think it really hits home how valuable occupational therapists and the skill sets that we have can be in a primary care setting. So next slide, please. I'm aware I have probably spoke rather quick. So lastly, so these are some comments, again, kindly shared by Dr. Karen McGorry, just giving her perspective of the value of having Chantel working in her practice. And she goes on to say occupational therapists are a missing piece of the jigsaw in patient healthcare, and it's a role that will continue to evolve and develop, something she wishes had been available a long time ago. Wonderful to have access to such a wealth of knowledge and experience. Gives her confidence as a clinician that the patient will be supported by a committed team. And finally, she also says that she's learning herself from the occupational therapy service about how to take more of a holistic view of the patient. Yeah. So next slide, please, and thank you very much for listening.
Thank you for that, Sophie. It was lovely. Does anybody have any questions for Sophie or for anybody else?
There's none that I can see in the chat.
I think that was a really nice way of summarising from the, it's nice to hear from a GP about the value that it's brought, and also some of those case studies. Mike's got his hand up.
Yeah, thanks. I'm a patient working with NHS England in the cancer programme, and I'm absolutely fascinated by the fact that occupational therapists deal with mental health. And as in my role with the Patient and Public Voices Forum with the cancer programme, the cancer task force split into two, and I ended up on the psychosocial support group that was looking at what we can do for cancer patients through COVID, post-COVID, and we've got a whole new ball game for you to play out there that's not been looked at, particularly when you're saying at levels 1 and 2. Specialist services do come down the track, but the amount of time that if you can sort people's anxiety out early on, going through a cancer diagnosis, that you, and I mean, sort of like from my point of view, I was diagnosed 8 years ago. The treatment's finished 6 years ago. But even today, I've had an outpatient appointment because the consequences of treatment, we're living with sort of like physical abilities, disabilities or handicaps, shall I put it that way, you know, so the consequences of the treatment all the time. So there's just so much in this for me. And as well as that, I mean, again, because I tend to sort of like be in a situation where I can look at the broader picture, is if you're sorting people out and it's the right person looking after the right patient, you're freeing up time elsewhere for other patients coming in. And it's just seeing the big picture. I have hold my hands up. A lot of the conversation has been about sort of like the commissioning and sorting things like that, what goes on in the background. We just see your face as the patient. You're the person who deals with us. But I mean, sort of like, what a great opportunity this is. So that's it.
That's brilliant. Fantastic, Mike. Thanks so much. I'm glad you can see the potential. And hopefully you'll be our advocate going forwards in your meetings that you.
Oh, absolutely, particularly around mental health with the cancer programme.
Yeah,
I've got a list of all the people that we come into contact, and it's a matter of sort of like making every conversation count. And it's sort of like you've just jumped up to the top of the list. Yeah.
Wow. Oh,
So,
can we? I've got goosebumps. Can we have this in quotes?
well, you're recording it. Just take it down. You know, it's yeah.
Yeah, Mike Thorpe said, quote.
Vice Chair of the Patient and Public Voices Forum, NHS England Cancer Programme.
Lovely. Humera,
Okay.
back to you.
Yeah, our final ask of you all this evening is just a few more questions to help us understand your knowledge of occupational therapy now. So can you please all join in once again?
Oh, it's back to me too. So first one is a bit of a multiple choice. Here we go. So now that you've seen, so this is the gauge, make sure we've done our right job in explaining tonight. So occupational therapists work with people who, so you can choose multiple options and just want to see what you think after today they can deal with based on that list. You should be able to, oh no, you can't do multiple options because I've done it wrong. So you can just pick one. Sorry. I thought I'd chosen the option to do multiple options, but I haven't done.
You can pop in the chat if there's ones on there that you can't click if you want to.
That's great. So quite a lot of people choosing the frail older adults, and then adults with health and work problems and adults with mental health problems. So no one's picked taking blood, medication review, or taking blood pressure.
Spot on.
Good. Right, I'm going to close. I'll stop this so it stops showing on screen. And then you can see the answers in there. So if you still want to answer, then you'll be able to just type in the chat. I think the only way to stop it from on the screen is maybe to launch the next one. So the next one now, this is employers. And again, we might have reworded it slightly different, but it's a case of perhaps PCN clinical directors or anyone looking at and employing them. Would you ever consider employing an occupational therapist in a general practice now, based on what you've heard? Let me launch that one. So I'm not sure how many employers we've got. So it's a yes, no, and a bit of a Y as well. So it comes up as a word cloud. Definitely like that. And because of the mental health and the dual workers and the physicality of it. So keen part of any multidisciplinary team. So I remembered what MDT meant that time. So it's good. So it does it. So lots of yes and lots of good reasons why. Just leave that up another minute or two before moving on. So we're going to ask the clinicians, the next, who are currently working in general practice, the same question. Do you want to, or similar question, do you now see the benefits of working alongside an OT? So I'm just going to close this one, and then launch that one. So here we go. Sorry, scrolling's gone wrong. So this is for like specifically for clinicians working in general practice. Do you see the benefit? And it'll be interesting if you could perhaps put what your role is as well in the comment and see how you think you'd work with them. That'd be really good. So we'll see who else is on who isn't necessarily an employer. So we might not have any clinicians. Oh, here we go. So we've got physio. Yes. Fab. A few responses without knowing who's on the phone now. So it's a bit difficult. You can still submit, but I'll launch the other one. It's in the chat. You can literally just click on submit and type. So we've got a GP saying yes now, fab. So this is for any OTs currently on the call and OT students. After learning today, would you consider a career within primary care? Good. Yes, straight away. It's always good. Totally. I'm going to delete me speaking. Leave it on the screen when I edit this video down. So fast-paced, dream job. That's good. Absolutely. It seems to have quite a few OTs and OT students in, which is good. So particularly the students. So in 5 years' time, you'll see us on another webinar promoting this, or hopefully you'll be the ones doing the webinar for us.
We've had our 2 occupational therapy students who've put this together and now they've had to deliver it as well, which they weren't banking on. So yeah, fantastic. This is the sort of workforce we've got, very responsive.
I'm just going to close that. So if it's still on your screen and you don't want to just close it, I'll leave it open again. So if anyone thinks of anything, they can pop it. It's just in the chat. And then that is the last question from me. So it's back to Mara to close up. And let me just bring up the slideshow.
Okay, so on the slideshow, there are a few resource pages for any links that you may wish to follow. Just wait. Yeah, so we've got a few pages of resources. Next slide, please. And again. So as for the next steps, if you're an occupational therapist interested in exploring primary care opportunities, then we would like to signpost you to the Greater Manchester Primary Care Careers page. Or if you're a part of a primary care network, then we would like to signpost you to the Greater Manchester Workforce Connect, which Johnny mentioned earlier. Next slide, please. If you would like to rewatch this webinar or share it, then there's a link to the Greater Manchester Training Hub that's provided on the screen now. And it's been wonderful to have you all with us this evening, and I hope you have found tonight's webinar informative and interesting. The team and I will be around for a few minutes should anyone wish to ask any further questions. And thank you once again, and thank you to the team and our guest speakers for your time and help.
Thank you, very informative.
Thank you. Yeah, thanks ever so much, everyone.
Could I just have the previous slide that had the, the contacts, the web pages? Can I just have that back up, or somebody put them in the chat or something?
No
I think we're going to send the slides out, are we, Rob, to everybody?
So I'll get the video. I'll put them up anyway, so you can make it up now. But I'll once I've uploaded the video to the website, I'll email it out either tomorrow or Monday, and then I'll add the slides to it as well.
Thank you.
And please do share with any colleagues, or especially our occupational therapy colleagues or our primary care network colleagues. So for those that weren't able to attend this evening, that would be fantastic if you could. And I'll put my details in there if anybody wants any further information, or they've got anything they want to ask.
I am hoping if you want to click, I think it should be an interactive PowerPoint. You should be able to click on the links as well, I think. Just going to stop recording now.